Welcome back, everyone. Our speaker is Professor Harmony Reynolds, who is Associate Professor of Medicine at the Grossman School of Medicine in New York. Her talk today is going to be very interesting on myocardial infarction with non-obstructive coronary artery disease and why women. Harmony, can you hear us?
I can. Can you hear me?
Lovely. Yes, we can. So a very warm welcome from London, and off you go, if that's all right.
Yes, thank you. Thanks so much for inviting me today. I wish I could be there in person. I'll be speaking about myocardial infarction with non-obstructive coronary arteries, or MINOCA. Why women? I think it's always helpful to have a case to ground us, and so we have here a 35-year-old woman with a history of high cholesterol, smoking, and obesity. She comes to the emergency department to report 20 minutes of left-sided chest pain, nausea, and sweating. Her ECG is normal. Her troponin is initially negative, but peaks at 0.86 on the old assay with the upper limit of normal 0.04, and then declines the following day. She has a coronary angiogram, and it shows 20% proximal left circumflex disease and luminal irregularities elsewhere. So what do we tell this woman? Do we tell her, you had a heart attack? Do we tell her, great news, it's not a heart attack because the arteries are open? Or do we look like this guy who's not too sure and say, I need more imaging in order to be certain? He looks uncertain, but he's the right one. So let's go into this. What is an MI? The universal definition of MI does not include anything about obstructed coronary arteries. There's no requirement. So AMI is instead when there is a rise and or a fall of cardiac troponin values with at least one that is abnormal, and either symptoms, which she had, ECG changes, which she didn't have, or imaging evidence of a new wall motion abnormality or perfusion defect, which again she didn't have. But she has symptoms and a rise and fall in troponin, and she even has risk factors. So she did have MI. But she has no obstructive coronaries. There is a standardized American Heart Association and European Society, actually, definition for MI with no obstructive coronaries. And again, it's centered on meeting the universal definition of MI. But also, there are no obstructed arteries at angiography. And this can range from angiographically completely normal arteries through mild coronary disease, as this patient had, all the way up to the 45% stenosis mark. And whenever we talk about what MINOCA is, we always talk about what it isn't. It isn't a troponin that's elevated for an entirely different reason than MI. It's not, for example, a troponin with a pulmonary embolism. It's not a sepsis-related troponin. And if you encounter a patient who clearly has myocarditis, an 18-year-old man with influenza who otherwise looks like he might be having heart attack, well, you know that's myocarditis. So you wouldn't call it MINOCA because you wouldn't call it MI in the first place. MINOCA disproportionately affects women. Here are data from 3 studies, but there are many studies showing this. Let's start with ST elevation myocardial infarction. You can see here that 4 to 10% of female STEMI patients have no obstructed artery at angiography, along with 2 to 8% of males. When we look at non-STEMI, the difference by sex is even more striking. It's up to 15% of women with non-STEMI who will have no 50% or greater lesion at angiography, and only 4 to 5% of men. We teamed up with the New York City Chief Medical Examiner and learned that MINOCA can present as a fatal problem. When examining patients at autopsy who were aged under 55 and had pathologic evidence of myocardial infarction, 23% of the females and 16% of the males had no badly obstructed coronary artery. MINOCA is also more frequent among younger patients and patients of Black race or Hispanic ethnicity. When encountering this syndrome, clinicians and patients will ask, was this really a heart attack? What is the treatment? What's the prognosis? Let's start with the prognosis. This graph shows in-hospital and long-term mortality after a MINOCA event, and the gray represents actuarial mortality of a population of similar age and sex in the United States. We can appreciate here that the in-hospital mortality of MINOCA is just over 1%. That's been shown in many studies. A meta-analysis that recently included over 30,000 patients gives us a 1-year mortality of 3.4%, much higher than the normal. And the 4-year mortality from the large Sweetheart registry was 13.4%. So this is not a good thing to have. Major adverse cardiovascular events definitely accrue after MINOCA. Again, from the large Sweetheart registry, I talked to you about the mortality rate. The 4-year recurrent myocardial infarction rate is 7%. heart failure 6%, and with a 4% risk of stroke, that comes together for a 24% four-year rate of major adverse cardiovascular events. In looking at a 16,000 patient study restricted to patients older than ours in our sample case, the one-year death rate was 12%, 18% one-year rate of major adverse cardiovascular events. And in that large meta-analysis I mentioned, the one-year rate of major adverse cardiovascular events across all ages was just under 10%. Predictors of adverse outcome across studies are ST elevation, lower ejection fraction, and older age. These event rates are always lower in every study as compared to MI with obstructive coronary disease, but as I showed you, they're much worse than in the general population. Makes sense because it's a heart attack. The best treatment of this problem is unknown. No treatment trials have been performed. One is underway. For now, we use mechanistic and observational data to guide management. In order to do that, we need to understand all of the mechanisms of MINOCA, and they are quite variable. It can be from plaque rupture, as shown on this OCT image with a rupture in a lipidic plaque. It can be due to plaque erosion, which is thrombosis on an intact fibrous cap of a plaque. It can be from coronary artery spasm. Rarely, MINOCA is due to coronary dissection. MINOCA may be due to in situ thrombosis or thromboembolism. And then we have the overlap syndromes of Takotsubo Syndrome and myocarditis. And in this case, this is myocarditis that you were not expecting before you did a cardiac MRI. I'll remind you, there's always a differential diagnosis to an elevated troponin. Whenever we encounter an elevated troponin, we must consider whether it is chronic myocardial injury because it's a flat, stable troponin. If it is acute myocardial injury, rise and fall of troponin, but not an ischemic mechanism, like acute heart failure or myocarditis. And then if we think there is a troponin rise and fall with acute ischemia, we must decide if that acute myocardial infarction is from atherothrombosis or from something else. So this approach to MINOCA is really not different than what we do with all heart attack patients, or really everyone with an elevated troponin. Coronary angiography is an extremely important test for all patients with MI, but it has its limitations. This classic example illustrates what I mean. Here is an LAD coronary angiogram, and the lumen looks smooth and even. But if we take pictures from inside the artery, we get a different flavor. At this site, we have a normal intravascular ultrasound. Here's the intravascular ultrasound catheter. The lumen here measures 3 millimeters, and then we have a nice small intima, media, adventitia, and perivascular tissue. But at this spot, which looks the same or even better on the angiogram, we have this intimal thickening that is an eccentric plaque. So we know that the angiogram can hide things. What about plaque rupture or erosion? That too is not always angiographically evident. This is a schematic of a cross-section of a plaque. We see a necrotic core, smooth muscle, and inflammatory cells. And if this plaque were to rupture and we were to have a thrombus that looks like this, we would see an obstructed appearance on an angiogram. But if the thrombus instead is this size, we might not see that at all. And yet this thrombus may embolize and cause infarction of myocardium downstream. The same concept applies to a plaque erosion, where there is a different underlying plaque morphology, more smooth muscle and proteoglycans. And in this case, denudation of the endothelium is thought to lead to thrombosis. But the principle is the same. If the thrombus is small, then it might still cause an infarct without causing an angiographically obstructive appearance. How common is this? There are several single-center studies now using intracoronary imaging with ultrasound or optical coherence tomography. And they've demonstrated plaque rupture, erosion, or thrombus in 29 to 38% of patients with MINOCA. And this was 43% in a recent multi-center study that we called HARP. That rate is lower than in ST elevation MI patients who have obstructive coronary disease, but it's higher than in asymptomatic patients who have some stable coronary disease. And in stable ischemia with non-obstructive disease, several studies have shown you never get plaque rupture or erosion. Again, this is heart attack. In one study in which myocarditis and coronary spasm were evaluated and ruled out before OCT was performed, almost everybody had plaque rupture or erosion. And one might think, I would have thought, that the angiogram would be helpful in targeting the spot that has the active plaque. But unfortunately, it isn't. In our multi-center HARP study, we saw that 30% of patients with MINOCA, they were women, who had a normal angiogram as determined locally, had an OCT culprit lesion on review. And the culprit is only located in the worst plaque on angiography half the time when it's present. So the angiogram really can cloud the picture, or not cloud the picture, but it may not give us the whole story. We need intracoronary imaging if we truly want to understand whether plaque disruption is the cause of a MINOCA event. I'm often asked, if this thrombus is not occlusive, what's causing the myonecrosis in the setting of a non-obstructive plaque rupture or erosion? And when we did multimodality imaging studies, we've seen two major patterns. One pattern is that there is a large area of myocardial injury. On this cardiac MRI with the blue arrows, you can see these whiter areas. In this case, this is myocardial edema in the LAD territory, the anterior wall, anterior septum, and apex. This corresponded to an LAD proximal plaque rupture. I imagine then that this artery must have been transiently severely narrowed or occluded. And the only two ways I can think of that would happen is either that there was superimposed coronary spasm, or that there was transient, much larger thrombosis with spontaneous thrombolysis. The other pattern that we commonly saw were small myocardial infarctions, as in this example where we see a very focal area of transmural late gadolinium enhancement here in the basal inferior wall, seen again here. And I imagine this is embolization of atherothrombotic debris, very much like the schematic I showed you with the small thrombus. Let's turn to coronary artery spasm. This is a common cause of MINOCA. Sometimes we see spasm spontaneously at coronary catheterization, but provocative testing is most accurate to find it. Provocative testing is not routinely done at the time of the acute angiogram because of the risk of worsening infarct and of complications, but some studies have used acute provocative testing, and 1/4 to 2/3 have induced spasm. This is true also if you bring patients back within the first, let's say, month. The spasm type may be the traditional epicardial thing, where there is transient 90% narrowing of the artery that's reversible with nitroglycerin. But about half of it is microvascular spasm, which is something that's increasingly being recognized. Microvascular spasm happens when on the angiogram you may see minor narrowing with acetylcholine or no change, but the patient's symptoms are recapitulated with EKG changes. Most patients with spasm also had some plaque. This is a long-standing observation. And we've learned recently that myocardial bridging may be a clue to coronary spasm because acetylcholine testing was abnormal in almost everyone who had a myocardial bridge in one MINOCA series. Predictors of coronary spasm and MINOCA are significant but not very strong. The spasm patients tend to be a bit younger, they're more likely to be male, they're quite likely to have typical chest pain, and to have had prior chest pain, that's a bit more likely with spasm. We typically think that ST elevation with pain must go along with spasm, but we're increasingly learning that's not always the case. And the EF is a bit more likely to be preserved. But the traditional coronary disease risk factors, as in our patient, and the vital signs, the peak troponin, they don't predict spasm. They don't make it more likely, but then again, they don't protect either. And it should be noted that most patients with MINOCA have at least one coronary risk factor. Now, initially, I showed you patients being sorted into very neat buckets, but the likelihood is that MINOCA is multifactorial. This study used optical coherence tomography at the time of an angiogram at the site of spasm right after spasm was provoked. And they see that there may be a small rupture or a plaque erosion with this thrombus here quite frequently in patients at a site of spasm. It's unusual, in fact, for that spasm site to look normal on OCT. Thrombosis is certainly a part of MINOCA, and it may be the entire cause in some patients. Up to 24% of MINOCA patients may have an inherited thrombophilia, whether that's factor V Leiden, protein C or S deficiency, or antiphospholipid antibodies. That frequency is similar to cryptogenic stroke. When looking at patients with MI who have antiphospholipid antibodies, about 20% have MINOCA. Compare that to about 8% overall. We've noticed an association with exogenous hormone use. We've seen a couple of in situ thromboses in patients who had high-dose hormones used for heavy menstrual bleeding, for example. Coronary dissection is a cause of MINOCA, but I always like to dispel the notion that these two things are together because they both disproportionately affect young women, and so they are sometimes conflated. Coronary dissection is, of course, this problem of intramural hematoma, where there is bleeding between the media and adventitia of the vessel that can transiently or completely occlude the artery. That gives an angiographic appearance typically that will look like this. You can see that at the site of the arrow, there's a very abrupt change in caliber of this artery, and that smaller caliber is maintained all the way down the vessel. That's from coronary dissection. It's an angiographic diagnosis. Rarely, though, you will see an angiogram that shows minor narrowing. And it may not be apparent that's from dissection. And it may only be with intracoronary imaging that you'll see this intramural hematoma. I think you may be able to appreciate this crescent shape here. This proportion is probably single digits on both sides. So among patients proven to have coronary dissection, just a couple of percent had it with non-obstructive appearance and were diagnosed by intracoronary imaging. And among MINOCA patients, somewhere between 1 and 5% will be shown to have dissection when intracoronary imaging is used. Myocarditis is an important alternate diagnosis found on cardiac MRI. And when we talk about myocarditis here, we're usually talking about what I like to call now surprise myocarditis. You didn't think it was myocarditis going in, the patient had the angiogram, you still think it's an MI, and now you do a cardiac MRI and surprise, it's myocarditis. This CMR pattern is diagnostic, and you can see here that this patient, since white is abnormal on this and black is normal myocardium, we see this epicardial abnormality of late gadolinium enhancement, some that starts in the subendocardium but goes into the mid-myocardium, some on the right ventricular side. This non-ischemic pattern, not respecting a coronary territory and more towards the external area of the myocardium, that's diagnostic. This pattern is present somewhere between 15% of the time to about a third in patients clinically diagnosed as MINOCA. And it's more common in patients who have angiographically normal coronaries, among men, and in younger patients. This is an extremely important diagnosis to make because once the patient is through the acute illness, the treatment is just supportive, right? There are no antiplatelets, no statin therapy, as opposed to the 4 or 5 drugs that we're giving on discharge with myocardial infarction. Takotsubo Syndrome is a mimicker of MINOCA, and I think that our understanding of this problem is evolving. At the moment, it is not categorized as MI, but that may change. It is a reversible left ventricular dysfunction syndrome with elevated troponin and typically non-obstructive coronary arteries, certainly not enough coronary disease to explain the profound wall motion abnormality. The diagnosis may be suspected based on a specific wall motion pattern, especially the apical ballooning pattern. And it may be suspected because it is often triggered by physical or emotional stress. But of course, cardiac catheterization is still needed, and acute myocardial infarction can cause a similar wall motion pattern, whether it's due to thrombosis, spasm, plaque rupture, dissection. Cardiac MRI may be useful to differentiate Takotsubo syndrome from infarct. Takotsubo syndrome will classically have circumferential myocardial edema affecting the mid and apical segments and no area of late gadolinium enhancement. The cardiac MRI finding of cardiomyopathy, including and especially, in fact, Takotsubo syndrome in a potential MINOCA patient, has a prognostic impact. Those Takotsubo patients had a much higher risk of death than everyone else, even infarct patients. One hypothesis about how this is mediated is through microvascular and multivessel spasm, and that's why I say if it ultimately proves to be a vascular problem, someday we may recategorize this as MI. But for now, it's separate. The European Society of Cardiology has guidelines for MINOCA. For non-ST elevation acute coronary syndrome, there is this subsection on myocardial infarction with non-obstructive coronary arteries, and they give us these recommendations. In all patients with an initial working diagnosis of MINOCA, it is recommended to follow a diagnostic algorithm to differentiate true MINOCA from alternatives. It's recommended to perform cardiac MRI in everyone, to manage patients with an initial diagnosis of MINOCA and a final established underlying cause according to disease-specific guidelines. So let's see, how does that go? Here is a diagram showing us how to evaluate a MINOCA patient, and the ESC guideline is very similar, but this one's just a little easier to show. We start with the clinical presentation of somebody meeting the myocardial infarction definition and having non-obstructive coronaries. As we talked about with the MINOCA definition, we pause for a moment and say, did we miss something? For example, pulmonary embolism. A series of 100 consecutive MINOCA patients with CT to rule out pulmonary embolism found none, but occasionally we're surprised. If we've ruled that out, we say we have a working diagnosis of MINOCA, and we must look carefully at the angiogram for missed findings. I'm a non-invasive cardiologist, but the invasive cardiologist will say the same thing. It takes take a breath, look at the angiogram. Sometimes you will find, oh, there was a dissection, there was a branch vessel cutoff we missed. Do a left ventricular functional assessment to see if you think it's Takotsubo syndrome or another cardiomyopathy, and do the cardiac MRI to rule out myocarditis. Then we say we have a true MINOCA patient in whom we think the underlying cause is vascular. We may consider intracoronary imaging to see if there's plaque disruption. We may consider a coronary functional assessment for spasm. In the multi-center heart attack research program, we looked for the frequency of each underlying cause using OCT of 3 vessels and cardiac MRI. And when we put it all together, we found that myocardial infarction was the cause in 64% of our women, myocarditis in 15%, 3% each Takotsubo Syndrome, and non-ischemic cardiomyopathy. And we could not identify the cause on multiple modality imaging in just over 15%. When we looked at the OCT findings, usually if there was a culprit lesion, and that was in almost half the patients, it was from a plaque rupture or the early sequela of plaque rupture. In our patient, there was a circumflex thrombus on OCT, and this is quite typical of the MINOCA in that the plaque is small. Just to orient you again, this is the OCT catheter, the guide wire, it makes a shadow here, and we expect a normal appearance like this: intima, dark band of the media, adventitia, perivascular tissue. But here we don't see the media anymore because there is some intimal plaque, and we should never get this kind of protrusion and irregularity that you see here. That's thrombus. Her MRI shows an infarct in the circumflex territory. This is a ball-shaped embolic infarct and really looks like there was a larger thrombus here and it embolized. So we're supposed to now we're recommended to manage her according to her final established underlying cause. In her case, that's an active plaque with thrombus. So we've given her antiplatelet therapy, statin, and a beta blocker, and an ACE inhibitor. If we didn't have a final diagnosis of a specific cause, we would use secondary prevention according to the usual guidelines. Why the ACE inhibitor? That stems really from this observational study of secondary prevention after MINOCA in Sweetheart. They did propensity matching to match cohorts who were treated in red or not treated in blue with each of these individual drugs. And you can appreciate that over a mean follow-up of 4 years, that statin-treated patients seem to do better. This is, of course, confounded by selection, but it's interesting. ACE inhibitor assigned patients did better. There was a trend towards better outcomes with beta blockade that did not reach statistical significance. And to my surprise, considering the frequency of plaque rupture and erosion, dual antiplatelet therapy was not associated with a signal towards benefit. Of course, we need randomized trials, and the MINOCA-BAT randomized 2x2 factorial trial of beta blocker and ACE or ARB is enrolling now. So I was asked to talk about why women. This is the hardest part of the talk. I'm not sure. MINOCA culprit plaques are a lot like MI with coronary disease culprit plaques, but they're smaller. Just to give you an example here, here's a plaque rupture in a MINOCA patient, and we can see that there's definitely plaque there, but the lumen has plenty of room. Here's a plaque rupture in a corresponding MI coronary disease patient. Very small lumen, much bigger cavity, much bigger plaque. And that's typical no matter which cause you look at. And women do have less severe and extensive coronary artery disease. Here from the ischemia trial, the randomized patients who did have obstructive coronary disease, we can see that fewer of them had triple vessel disease, more had single vessel disease. But this is true in so many studies, in the Barry 2D randomized trial, in coronary CT studies, in asymptomatic patients, in symptomatic patients. No matter how you slice it, even if you take out the non-obstructive patients, women always have less severe and extensive coronary disease. So maybe that's just a female phenotype. We also did, this is sort of a tantalizing bit of data, we did whole blood RNA sequencing in some of our MINOCA patients. And you can see that as we compare MINOCA to controls who had non-obstructive disease and did not have MI, there are quite a lot of differently expressed genes. When we compare MINOCA to MI-CAD, many differentially expressed genes, you can see the volcano plots there. And what was the top hit that was most different in both MINOCA versus control and MINOCA versus MI-CAD? Estrogen receptor signaling. So this is a very interesting lead that we are going to follow to try and figure out why women are more likely to have MINOCA than men. We're also going to look at sex differences in MINOCA mechanisms in the follow-up to HARP, which will include 300 men and women with MINOCA, who they'll have 3-vessel OCT and cardiac MRI, and we will look at biomarkers and genetics and platelets and whole blood. So the take-home points today, MINOCA. Is it MI? Yes, about 2/3 of the time. So this was the correct doctor. You had heart attack with open arteries or MINOCA. We might say more testing may help us figure out why this happened to you. It might help me understand which medicines you need if we follow the ESC guidelines. These patients may look very similar when you initially approach them, but when we use imaging of multiple modalities, we can see what's going on inside, and it may be quite different, kind of like a box of chocolates. When do we apply this testing as it stands today? Cardiac MRI for everyone. OCT should be considered strongly when you'll change your decision about antiplatelet therapy based on the results, especially if somebody, for example, has bleeding risk. If you suspect but cannot confirm dissection, for example, a young woman with no risk factors who has some degree of stenosis that was not clearly due to dissection. You may choose to do this simply because you want to know the diagnosis with more certainty. People like to know their diagnosis. But one must recognize you may not be right about the culprit vessel, especially if cardiac MRI was not done first, and so multi-vessel OCT would be the norm. I consider spasm testing mostly in follow-up for persistent chest pain. How do we treat when the underlying diagnosis is uncertain as it stands today? Again, the ESC guideline says use the usual secondary prevention complement. Antiplatelet therapy. I use a statin unless I am completely sure there is no athero, and a CT coronary may be helpful here. I use calcium channel blockade in case there might have been spasm. I use ACE inhibitor ARB based on Sweetheart. And I restrict beta blockade to patients who had an infarct on MRI, like the sample case that I showed you, who have low ejection fraction, or if I suspected dissection based on observational data. Thank you very much.